We've got a few residual people in the hallway, but I think we will get started. So I'm going to be going through in a whirlwind fashion 2 slide decks that are promised for this morning, and then we're going to have some guidance over lunch as to exercises we'll be pursuing this afternoon within each group. We will then be continuing on to exploring a little bit more some of the modeling methods that I'm going to be introducing in a very brief form this morning. Okay. So the first thing I want to talk about was sort of motivations for system science, and expanding on some of what we've seen already, that buzzing, blooming confusion that you were grappling with just an hour ago, trying to make sense of it all and trying to link it in with sort of health priorities and needs when it comes to particularly decision making in health and healthcare. I'm going to be providing a brief introduction to sort of dynamic models as a whole, and then briefly characterizing 3 types of system science methods that happen to be the 3 types supported by any logic, but also happen to be very, very current in terms of the interest in them in the health area. Okay, and that will sort of complete the conceptual grounding that I'm hoping will keep us through the boot camp. So I think much of the motivation for system science, I'm going to be going through this very quickly. Much of the motivation for system science lies in what my colleague Bobby Milstein calls the desire to redirect the course of change when it comes to health. This graph shows reported cases of chlamydia over time for males and females within Canada. It's from Tom Wong at Public Health Agency of Canada. And what you see was here was a very encouraging, taken as a very encouraging sign in the late 90s. This situation seemed to be that we had sexually transmitted infections on the run. We had declining reported cases of chlamydia, and that was a result of a great deal of investment in contact tracing, in improved assays, particularly in the later part of that decade, and in greater understanding of the contact networks and some innovations in service delivery. In subsequent years, what we saw, however, reversed that change. We saw rising rates of chlamydia starting Canada-wide in about 1998, differing by provinces, growing to rates that by the mid-2000s were eliciting calls of being really in an alarming type of situation. Unprecedentedly high rates of chlamydia, and many were calling it a real public health crisis. Now, within this context, many important questions arose about how could we best reverse these raising rates of chlamydia? How could we most effectively turn the tide, as it were, so secure the health gains which have been so seemingly at hand in the late 90s? And a number of hypotheses were advanced to explain these rising rates that suggested different avenues for moving forward. Many of those analyses were buttressed by modeling approaches as lenses to help advance them. And some modelers even called into question whether these rising rates were indeed the sign of a crisis or the sign of ever more effective reporting and the ability to sort of drain the swamp by identifying cases. So, there's some very important questions here. What's going on here? Is this good or bad news, these rising rates here? Is it a reflection of better case finding and more effective identification of cases in their early stage? But also, how can we bend the curve so that over time we can see lower and lower rates of actual underlying incidence? And these are the sort of questions to which modeling is very well suited. There's also many issues we know we deal with in the health sphere that are incredibly tangled issues. Issues that initially may seem very biomedical in nature. having to do with the link between weight and diabetes are often nested in social contexts and cultural contexts, which are actually quite complex, quite textured. And if we want to put in place fixes that stay fixed for issues such as this, as Jeff is fond for saying, we need to grapple with these successive layers of complexity, which may start at an individual level, but quickly encompass, as you look out from there, aspects of family, aspects of culture, aspects of regulatory mechanisms, protective mechanisms, and aspects of cultural norms and attitudes and beliefs that are very tangled, not just being purely biomedical in character, but in fact tangled at multiple levels of analysis. So, there's these layers of issues that involve not just, individual risk factors at a purely linear level, but complex physiological regulatory processes. The fact that once we gain a certain level of weight once and lose it, it's easier to regain it the second time, for example. The fact that as we try to lose weight, our body metabolism thinks we're starving and actually tries to slow down and keep us from losing more weight. It makes it harder to lose each successive kilogram. And there's diverse actors involved. In the obesity and diabetes front, we have consumers for sure, the patients that are sometimes forefront of our analyses, but also retailers, agricultural producers, the weight loss industry, lobbyists and regulators. There's a whole group of different parties, and many of them have significant stakes in the game when it comes to putting in place rules governing sugar-sweetened beverages or governing fast food, etc., and its marketing to kids. There's this key role of environment, social networks, built environments, food environments, communicational contexts that can shape behaviors in important ways. There's also shifting norms, attitudes, and beliefs regarding body weight, regarding what a healthy meal is, a good meal, and then there's syndemic interaction with other conditions such as metabolic syndrome and gestational diabetes that we've documented in some of our works, and that at an intergenerational level may bring in place some additional regularities that need to be thought about. And so it is with many conditions, heart disease, oral health, the work that Robin's doing, work involving communicable diseases. Often we have these narratives which may start looking simplistically simple, start looking misleadingly simple, but then expand into entangled interactions with many, many factors. So key features within many of these contexts are developmental schedules, diverse actors, critical periods, sometimes dynamic of relationship, the need for a Lifecourse perspective and understanding consequences, perhaps of early life insults, perhaps of early life exposures, cross-sectoral nature of concerns, interactions between diverse services, not only classic medical individuals, but folks in allied health professions, and sometimes the difficulty in measuring key outcomes using traditional measures. Within the food environment, much work has provided levels of textured understanding as to the different layers of issues and their interaction within the context of providing us with nutritional options and incentivizing certain types of purchasing behavior. These types of spheres not only start with sort of aspects of physiology, but get into politics and governance, sociocultural, science and technology, economic factors, aspects of the environment, etc. So we're dealing with very, very textured and multi-layer environment. This from Shariki Kunaika, who documented sort of several levels of nesting, and this from the Foresight Institute in the UK, of course. Within this context, we're grappling with systems where, as I put it earlier, the whole is greater than the sum of the parts. They're composed of pieces, but it's not merely the pieces that matter, it's their interactions that matter. The fact that we see not just behavior that's suggestive of not just what comes from each little piece, but surprising emergent behavior is a result of the fact that we're dealing with a complex system, a system where we do have this behavior of the whole that transcends that of the parts. And the patterns that are seen in these systems are quite different, what we expected for any one component of the system, or the average or the sum of what we see from those systems. And one of the reasons this really matters, one of the reasons it's not merely a matter of intellectual curiosity, is that if we want to change something about the system, say through novel policy instruments, it's not clear how those changes will ripple through the system, how quickly, how fully, to what degree they'll achieve our aims, and to what degree they may have side effects. So, for example, we understand that caloric expenditure and physical activity doesn't translate into energetically equal levels of weight loss, for example. So Kim Thompson's work in the pages of the Lancet have demonstrated beautifully how overly narrow application of cost-effectiveness criteria in the context of polio, for example, can lead to disastrous sort of outcomes in terms of cost-effectiveness writ large with a broader sense. It can lead to the continuation of a endemic level of polio that's extremely expensive compared to the opportunities for eradication in the short term. And we know that physiology and immune function is just a piece of the puzzle as regarding how disease spreads through the population or in the context of chronic disease. So within these contexts, there's many needs. Two of them that I'm going to highlight are the need to explain, to ask what's going on. We see some empirical data. What's driving that? Does this evidence that we see, is it supportive of this hypothesis or that hypothesis? Which hypothesis is most consistent with? Where's the situation likely to go next? Where are we headed? What's driving these patterns? What are the primary drivers? And am I seeing a good or a bad indication? Is that growing rates of reporting of chlamydia? Is that a good thing because we're draining the swamp, or is it a bad thing because it means more underlying incidents? What's going on? And for many centuries, observers have noted some of these patterns that we observe at the higher level, which are very distinctive. They transcend anything we note at the individual level. So here, for example, we have recorded deaths from bubonic plague in the 1700s, describing the classic bell-shaped sort of epidemic curve. And in other cases, observers have noted the sort of periodic pulses associated with childhood infectious disease in Wales and in England on the left, or in our home province of Saskatchewan here on the right. These sort of patterns that had puzzling links to the biology of the infection and weren't merely reducible to it, but which imposed very significant health burdens on the population at the time. We know in the context of a lot of systems, including this interaction between caregivers and children, such as Connie and Carol Ann are so highly involved in, we often have different modes. And we see this within the context of a lot of interpersonal interactions, say within the context of relationships and marriage as well. We also see it, interestingly enough, in a lot of projects. You can have a situation which is very, very positive, very supportive on both sides, but it can get into situations where it unravels into a situation where each side is in a kind of vicious cycle of sorts. So you can have stable points that are favorable and stable points that are unfavorable, and sometimes tipping it from one to the other isn't all that hard in the context of life's full of stresses. We also see from the work of Christakis and Fowler and others, evidence to the fact that networks around us shape not only the pathogens to which we're exposed, but the attitudes, knowledge, and beliefs and risk factors such as obesity that have normally been considered in individuals in isolation are often associated with significant social network properties. That means that if I have several individuals, say, who are obese, I'm much more likely to be obese. Although it's brought up the questions, what's really driving it at a mechanistic level? We see for infectious disease as well as chronic, spatial patterning that's very pronounced. For example, for chlamydia, within the context of Canadian cities here in Manitoba, the spread of networks, the spatial spread of zoonoses like rabies. So when it comes to explaining patterns, which is often a real need to take this next step and reason about where to intervene, we're often confronted with patterns that are very hard to understand in light of the pieces. We need to reason about how those pieces fit together in ways that yield a whole that's greater than the sum of the parts. It's a pronounced feature of the health context. Within the context of the AAA, John Berwick talks about, on the health services side, how many problems within the health care sphere are caused by sub-optimizing pieces of the system. You're attempting to optimize your little sphere of the system without realizing its many interactions and dependencies and interdependencies with other areas of the healthcare system, and you end up with something that seems, optimized from your standpoint, but where it's led to really adverse behavior for the system as a whole. You seem like you've gained something, but once you consider your interactions, it's actually penny-wise, pound-foolish, as it were. A second major need is the need to intervene. So we need to explain. We need to explain to be able to understand where we're headed, what's causing what we've seen, and to be able to sharpen our understanding of what's really going on. But we also often need to intervene. We want to ask, what can we change to make the situation better? At what stage and set of processes? Prevention, screening, prophylaxis, treatment? On which target groups? In what order, right? If you're thinking about the rollout of a vaccine for an emergent infection, say H1N1, who do we vaccinate first? Pregnant women, healthcare workers, young children with high rates of contact. There's lots of thinking that could be advanced for this, and lots of uncertainty that's often present. How to best intervene? And sort of from a more detailed standpoint, how do we go about achieving a certain goal for, say, a change in incidence rate associated with teenage uptake of smoking? How soon will I see effects? How do we scale up effectively? These are often implementation science concerns, right, that really come to the fore when you're putting in place an intervention at a practical level. You don't want to declare an intervention dead before it's barely had time to show effect. And you're not quite sure how long do you have to wait. What sort of monitoring do you have to put into place to make sure that you're picking up those effects? How can I make this implementation financially sustainable when coupled with other interventions? There's a lot of interest in intervening in a way these days that takes into account network context. For example, identifying bridging individuals who span multiple communities and maybe important gateways not only for pathogen but knowledge, attitude, and beliefs. Taking advantage of assortivity, the fact that there's homophily, people like to spend time around others. Or taking advantage of the fact that often there are these core groups that have suffered disproportionate burden of certain health conditions, and maybe for the case of certain types of pathogens, preserving it at an endemic level within the network, an infection that otherwise wouldn't be able to survive. So if we want to intervene, maybe targeting those core members of the group. And often this is in the context of huge amounts of heterogeneity, where we sometimes have small groups within the population who are sort of the shapers of the dynamics we see. They're the tail that wags the dog when it comes to the overall health, public health outcomes. Now, for these needs, we've long done very, very well in health with reductionist methods. And reductionist methods have many, many things to recommend them, and they will continue to offer profound value within the health context. They have led to great insights concerning the function of the human body, concerning the pharmacokinetics and pharmacodynamic interaction of different drugs with human body, and have allowed us insight into that's allowed us to create many powerful interventions as well as medical devices, particularly at a small scale level. But it has this sort of work, reductionist efforts, the taking apart a system to understand the pieces, has great benefits in certain areas, but it yields limited insight to how all these pieces fit together to yield the outcomes at the system level as a whole. It provides limited ability to reliably understand policy trade-offs needed to remedy patterns when we have these entangled systems. Limited capacity to reason about impacts of novel interventions which have never been seen before, and where we need to go beyond what we see in a randomized controlled trial, where we're often controlling for the very factors that are going to be most important in shaping the success of the intervention in the real population. Reductionist methods have yielded great understanding of certain links that operate, but often provide limited understanding of the links between what is known at the micro level and at higher levels of sort of observed patterns of health outcomes. And have again limited ability to address multi-condition syndemics, such as we see between substance abuse, violence, and addictions within the context of certain low-income communities, or increasingly between chronic diseases like diabetes and other conditions linked to them through adverse immune impact or other factors. So, making decisions in the context of health is risky, absent insight as to how the pieces affect the whole. And, the question that I like to bring forward here is one that Jeff likes to highlight, which is, how do we arrive at fixes that stay fixed? How do we avoid fixes that simply blow back and dilute themselves? How do we avoid fixes that work for a little bit and fail? How do we avoid fixes that work at a small scale but don't scale up? A lot of opportunities here. One of them is the phenomena of tipping points. We know from the infectious disease area that sufficiently fast delivery of treatment or high enough vaccination rates can prevent infection from being able to establish itself. We saw that in that little model this morning, right? We ran it with a small enough recovery time, and the infection didn't even get started for many of the runs. And it may be that individuals are vulnerable, are not immune, but there's a level of herd immunity that's established at a certain point by a robust enough system to sort of maintain vaccination rates or maintain fast treatment levels. There are tipping points that can be achieved, and these tipping points are not limited to infectious disease, although they're best understood there. There are real tipping points when it comes to factors involving interpersonal relationships. There's real tipping points when it comes to the operation of a dementia ward. Jeff has spoken to me about the night and day difference, say, in a dementia ward between a ward which is led by a very experienced nurse who can sense patients perhaps at risk of getting agitated, acting up, and can head it off. And the ward managed by someone like that can be actually very much in balance, kept on an even keel, and be kept at a level that's conducive both to patient health, to caregiver, to formal caregiver sanity, and to comfort by family members. Conversely, if the situation tips and you have someone who's a little bit less experienced or too harried to be able to notice these effects early on, maybe that experienced nurse is lost and someone comes in who can't read the situation quite well, that same very ward with the same people in it can get in a situation where it's constantly fighting fires, where one person acts up, starts getting aggressive, starts getting upset, it upsets other patients within the dementia ward, and you have the whole ward constantly going in a firefighting mode. That's a difference of a tipping point. If you can get the right investment at the right time in the right way, you can have a night and day difference, a qualitative difference in outcomes. We also see this in relationships at a smaller level. You can get in a vicious cycle where things just go bad in a hurry and you end up in a terrible situation. You also see, profound illustrations of path dependence. Since the work of Barker in the UK in looking at the effects on children exposed to deprivation in the working class context of early 1900s and mid 1900s England, the effects of early life insults in terms of the long shadows they cast on later life health outcomes, in terms of chronic disease outcomes, in terms of immune system strength, in terms of length and quality of life. And we know that in many contexts, these effects of path dependence, where what happens to me early on makes a huge difference in my trajectory, are not limited to chronic diseases, but in fact are seen throughout health. So, traditional techniques have a huge and ongoing role within the health system toolbox. None of what you'll hear in this boot camp is about throwing out existing techniques. It's rather about supplementing the toolbox. And there's a lot of challenges that we can undertake with traditional techniques coupled with system science methods if they're joined together well. And traditional techniques left to their own devices have a difficulty grappling with many of these factors that are at the heart of what I've just been talking about. And these include tightly interrelated, causally tangled pieces, multi-pathway, multi-level health ecosystems, reciprocal causality, where A affects B and B affects A, where we have novel interventions that we want to examine that haven't been examined before, or portfolios of that intervention, where we're concerned about Lifecourse effects, and about the role of adaptation and learning and helping people to adapt or regulate effectively, and where we have where we're interested in understanding the distal impacts of changes at particular pieces of the system. And I had also highlighted earlier the system science component, sort of reasoning about scale up of logistical challenges, training, sustainability financially, and in terms of human resources. Now, in this context, if we're not able to have the right tools at the table, we risk a variety of outcomes. We'll see counterintuitive behavior that we don't understand. We'll misperceive something that appears bad as good, or vice versa. We'll encounter policy resistance. We undertake a change at one place of a system and it yields blowback, or it dilutes itself, so we don't see much gain. We may miss the opportunity to reach a tipping point where just a bit more investment could yield a big difference, a qualitative difference. And all of these things mean that we have real problems learning from our experience, taking a intervention that's worked well in Kelowna and translating it to Vancouver, taking experience secured in Britain and translating it to the US. We have difficulties in coordinating different actors, maybe different actors in different service networks who may be accidentally working at cross purposes. Difficulty planning and deciding what changes are best, which interventions, and in designing a system that's more robust and more effective, perhaps with appropriate feedbacks. And the health area is just littered with cases of well-intentioned interventions gone wrong. Cases where we've cut cigarette tar levels to help reduce harm to smokers, with the goal being less cancer, lower the burden of cancer, heart disease, lower the burden associated with emphysema by having smokers exposed to less carcinogen. What could go wrong? Well, it often ignored cessation. And so individuals who would have quit otherwise went instead to low tar cigarettes instead of quitting. And it's widely believed by the FDA and the Surgeon General's office that introducing low tar cigarettes probably did net harm. Seemed like a good idea at the time. It led to blowback effects that we live with even today. Same thing with cigarette nicotine levels. I cut some of my first experience 15 to 20 years ago in the health area modeling with tobacco-related policy. And in this area, the idea was, well, by lowering nicotine levels in cigarettes, we can wean people off them, lower their addictions. Seems like a great idea, but it ignores often behavioral feedbacks. So if I have a cigarette that has less nicotine per unit cigarette, I'm going to smoke more of it, or smoke it more completely, or inhale more deeply to get my fix. And as a result, it's believed that probably exposed people to more carcinogen because they were smoking more fully. And so it is with many types of interventions, many types of, in the history of health, where we've had what seemed like a sensible strategy, and we've ended up, throwing ourselves into a real pickle. As Jeff would say, a fine mess we've gotten ourselves into. The risk here, ladies and gentlemen, is if we are working without really understanding drivers, without really understanding what's going on and important elements for how the world works, if we don't have a way of learning more quickly about which theories are on base and which theories are off base, which theories jibe with the evidence and which theories don't, we risk putting ourselves in the situation of old King Canute as he was goaded by his advisors. He had been assured by his advisors that he was the king of everything in England. He could achieve anything he wanted. And he asked them, well, surely you don't mean not everything, right? For example, if I ordered back the tide, it wouldn't be very effective. No, they said, yes, Lord, even the tide will obey thine command. And he was brought to the Strand, and he demonstrated the foolhardiness of their recommendations. And so it is with many of our actions. If we don't understand the underlying nature of things, we'll be working at cross purposes with it, or at least we risk that. And we risk butting our heads up against walls that are not going to give out and forsaking opportunities which will be much more fruitful. So, motivations for system science approaches, we're dealing with complex systems. We're dealing with tangled interactions between factors that are very, very complicated and complex over time, that yield unexpected emergent results. And absent a way of understanding the underlying drivers, we will end up often in a bad straits. So the key here, from the standpoint of complex systems work, is that, look, the patterns that we see in the world, that growth, that epi curve from London in the 1700s, those patterns of childhood infectious diseases, those patterns we saw within chlamydia of very high burden regions of the network. These patterns are not merely isolated artifacts. They're not merely fragmented kind of factoids of observations. They're related to each other. They result from underlying processes of some sort. The patterns of ill health that we see, the syndemics, the disparities that tug at our hearts, these reflect underlying processes that connect diverse factors. And these factors are highly related. They're interrelated and causally tangled. And to really understand why these patterns persist, the thought is that we need to reason consistently about the processes that give rise to them. In order to correct them effectively, to get those fixes that stay fixed, we need to go beyond what the advisors to King Canute suggested and to really understand the nature of things, to understand the tides, to understand how systems work, to learn more effectively about the world, about what's driving what. And absent this, we risk working at cross purposes. We risk banging our heads. So system science, as a discipline, as a enterprise, seeks to provide this kind of science of the whole. Help us visualize, understand, and reason about implications of understanding hypotheses about underlying processes, and to test their consistency with evidence. This is not about providing us with crystal balls. Crystal balls will not be in the offering. They will not be offered by this boot camp, even per se. Instead, what this is it's about providing a way to learn more quickly, ladies and gentlemen, to learn more quickly about the world. It's not providing something that will predict the future perfectly. It's about spotting more quickly the inconsistencies in our thinking, the inconsistencies that would have been latent if we had just had them in our heads and tried to think through them. And it involves putting out in a public sphere our assumptions in a way that can be critiqued, refined, and brought forward collectively, and which can be tested against evidence in ways wouldn't be possible. Any of those things wouldn't be possible if we're still in our heads. The central way in which system science attempts this is through the use of dynamic models. And we'll be talking about what is meant by a dynamic model. But basically these models weave together representations of our hypotheses concerning how diverse factors might interact with empirical evidence. That model we saw this morning, it had a very impoverished, sort of stylized representation of things. But it was a theory, and it helped us understand the consequences of a theory. Consequences we might not have realized if we had just sat back and think about it. And by helping us represent how things might work, or the consequences of positing this versus that, they can serve as these thinking tools, labs for refining our thinking and sharing our assumptions with others. So within your binders, you'll find a bunch of signs advising a system science approach. And I'd suggest that you take a look at that. We'll be talking more about them in coming hours. But they include many of the components here that I've tried to cover. Emergence, for sure, but also things like feedbacks. Vicious cycles that people can get in. Interactions between parent and child, for example, or between informal caregivers and the patient that may govern their institutionalization. Path dependence, how an effect early on can make all the difference much later. The need to understand distal impacts in a very complicated system. Disproportionate impacts of heterogeneity and others. So I'd suggest you look at that. Let's talk about these dynamic models. So what are these models? Well, at a most basic level, they help us represent hypothesized causal relationships between different factors and how they interact over time. A mouthful, yes, but fundamentally they help us represent what may be going on. Maybe going on in the sense of what may be the drivers that are in place. They help us provide a way of examining diverse system-wide consequences of potentially counterfactual changes in one or more areas of the system. We depict the system, we say, what if we change this parameter? Or we added this transition. Remember that? We added this transition. We changed this parameter. What's the consequences for the other thing? What's the consequences for that ring's thickness? What's the consequences for how fast it travels? What's the consequences in terms of sort of the density of people inside the ring that are actually recovered, or what have you? In many cases, we'll be asking things that matter even more, like what's the consequences and burden of infection? What's the consequence in terms of cost, in terms of cost effectiveness? These models help us and other system actors to understand a variety of important things. Vulnerabilities of our system, places where it's vulnerable to failure or fragile, where it offers leverage points, places we can change things. We have a lot of leverage. We can change things more easily. It may identify ways of fruitfully changing system structure. If only we can put in place rapid reporting of this through a new process, it might help us much more effectively manage the outcomes and improve ways of different stakeholders working together. So what are the characteristics of these models? Well, one of the things that's really confusing here, and it's regrettable, is that these models go by very different names and different consequences. So sometimes they're called mathematical models. Sometimes they're called causal models. Not to be conflated with causal models in the statistical literature. Sometimes they are called mechanistic models. They're sometimes called models of the physics of the system or the plumbing of the system. Sometimes they go by different names of subgroups. Agent-based models, system dynamics models, discrete event simulation models, compartmental models, microsimulation models. You can add on and on. They go by different names, but The defining goal here is to examine dynamic behavior resulting from hypothesized causal stories. These are mechanistic models in the sense that they depict kind of the mechanics of the system, although at a certain level of abstraction. Kind of the physics of the system, how things work, what changes what, or what's hypothesized to change what. And the system is hypothesized to be associated with some state. That model we saw this morning, an individual state was given by what? What were the three possible sort of states someone could be in? Anyone remember? Susceptible, infective, and recovered, right? And in general, we're going to see models that are much richer than that. Where you might have those three states, but you might have attitudes towards care seeking as another sort of division. Yeah.
Since you mentioned the state, we're talking about models here.
Yeah.
You did include Markov models.
Yeah.
What does that fit in?
Okay, great question. So Markov modeling is a modeling type that has some similarity to some of the approaches we're going to be seeing. It differs in some of its capacity to take into account a couple specific factors. One thing is open populations, so populations where there's people being recruited and dying over time. Another factor is where you have non-linear effects, and this is probably the most important one. So within these models, as we'll see, it's a very notable feature that they're non-linear. What I mean by that is, for example, if you examine the impact of intervention A and intervention B independently, combining them together can yield outcomes that are very different than the sum of the gain from each in isolation. That's one hallmark. Another would be adjusting the value of a given assumption, given parameter, say in the model, doubling it won't necessarily yield double the changes from increasing by A versus by 2A can yield outcomes that are very different than twice what you see with an increase in A. But Markov models also are associated with a challenge associated with something that's called recursive dimensionality. And this is something we'll see with system dynamics as you try to take into account heterogeneity. But it does lead to a limit in terms of what they can represent, and particularly in representing transitions that vary. The chance of me transitioning, say me recovering, varies with the state of the system. Like how many people are also waiting for treatment. You can imagine my likelihood of getting treated might depend if there's lots of other people awaiting treatment too. It's lower, and that's something that we can capture as a nonlinear effect in system science models, but not in traditional Markov models. I'll see if I can come back to this when we talk about some of the particulars. But in general, classic Markov models, because they're because they're linear, you can actually solve them in what's called enclosed form. You can get a solution to them. Whereas these sorts of models, the way you typically solve them is you run them. You can't get a solution to them except by simulating them out over time. That's another consequence of nonlinearity. But I'll see if I can come back to this issue when we talk about the three types of modeling. Okay? Okay, so this is a key defining characteristic of these models, is the fact that we're simulating step-by-step evolution of the state of the system over time. And very importantly, related to the question that was just asked with Markov modeling. With Markov modeling, what's typically done is to simulate each person in their evolution over time, in their health state. Very powerful technique. And so there's great Markov modeling work that's been done, for heart disease or for cancer or what have you. What it doesn't so much capture is the state of the system is limited to a person. Typically with these models, ladies and gentlemen, we are simulating the whole population over time and the interactions between people in the population. But what's most critical is that the population state, the current situation in the population, the status of the population is being simulated over time as it evolves, just like it does in the world, right? We can imagine the population of Saskatoon here in its evolution over the past year, And so that's captured at a micro level within the model at the same time. And because those individuals may interact, we are simulating them at the same time in the vast majority of cases. An exception being certain micro-simulation models which have no interaction between people. Those are increasingly rare, or increasingly less common anyway. Now, because this model seeks to capture hypothesized causality, a key use of it is to examine counterfactual situations that have not been observed before. Now, these sort of simulations, these sort of mechanistic simulations, mathematical models, dynamic models of the physics of the system, they're fairly new, and they're relatively new in terms of widespread use in health. They've been around at some level for a long time, since the work of Kermick and McKendrick, but even before that, the work of Ross nearly a century ago for mathematical epidemiology concerning communicable diseases. Ross with some zoonoses, and Kermick and McKendrick with the spread of communicable illness among people. But they're comparatively newer in many other areas of health. But in many other areas of human endeavor, they are just to be assumed, right? You would never want to fly in a plane to Saskatoon or anywhere else unless the pilot of that plane had flown that sort of plane before in all sorts of weather conditions in a flight simulator. It'd be foolhardy, right? To be going up with a pilot that's never learned how to fly a plane in a thunderstorm. But it would be equally foolhardy to train pilots about how to fly planes in thunderstorms by sending them up in a real plane into a thunderstorm. That'd be crazy. You'd risk hundreds of millions of dollars of loss. So we use flight simulators. We use vehicular simulators to train kids in high school, right? We use traffic simulators to plan changes in streets. Throughout many areas of human discourse, simulators are to be assumed. And in health, they are starting to be increasingly commonly applied. What you will find is a great diversity in how people use these and how they think that they fit into the scientific investigation process and fit in with other methods. The distinct perspective that we like to pursue here, and this is one to which Jeff and I are both very committed, is models as sort of these thinking tools. Models that help us learn more quickly, more thoroughly, more deeply from empirical evidence by refining our thinking. They are emphatically not a tool that you build and trust. They are a tool that you build, you test, you learn from, you refine, and you evolve over time. It's not something you put your faith in once you build it and you just use it to make policy predictions. It's rather something that helps you learn more quickly than you'd be able to if your understanding of the system was trapped in your head. Because, ladies and gentlemen, maybe we do have data over time about the spread of infection in our population. And when we see that emergent pattern from our model, we can compare it with the data and say, it doesn't jive, it doesn't add up, it doesn't capture the cyclical nature of what we see in the real world, and it points us, we need to change our model. But it's not just changing our simulation model, it's often changing our mental model that goes along with that. It's being able to kind of spot an inconsistency that would have remained latent, unappreciated if we didn't have that model to add up the evidence. If we couldn't simulate it and see it just doesn't jive with the emergent patterns we see in the world. So models here are about advancing sort of our understanding of what may be going on in the world more quickly and making sense of and leveraging the empirical data that we have to our avail. And ladies and gentlemen, this world is increasingly chock-a-block full of empirical data. In some cases, if we don't have models to back up from in some cases, if we don't have models to help us make sense of it, it will be full of sound and fury and signify nothing. It will be a cacophony of numbers with little implication for what we need, what our choices are, how we should change things, what it means. To make sense of what it means, we need models, not just dynamic models. I spend a large part of my time with machine learning models. but dynamic models are a key factor when we wish to link it up to decision-making, to counterfactuals, to what-if questions. Dynamic models are the name of the game. So these models serve as kind of as part of this loop of thinking through how we think things might be, of making a simulation model that captures elements of that, seeing the consequences of that simulation model more clearly than we would have if it had just been in our head, using that to refine our sense of what's likely going on, maybe refining this model because we see something that just doesn't jive with our experience or the experience of the stakeholders we work with. But then also sometimes undertaking actions, interventions, or collecting more data from the world and using that to further refine the model. So it's part of a learning cycle. It's not this brittle crystal ball that is perfect or breaks. It's rather this way of learning more quickly, of helping us learn more effectively from this evidence, putting this evidence that we're collecting, this big data, to use more effectively. So these models serve in many purposes. My colleagues, Josh Epstein at Hopkins and Don, who's head of the School of Public Health at Pitt, they've documented dozens of use of these sort of models, and some of them are listed here. So at a most fundamental level, folks, they take things that are in our head, pause it in our head, and they take them and put them on the plate in a common forum so that we can discuss them, we can critique them, we can refine them over time. They also aid in learning more quickly and more fastly from evidence. That's what I've just been emphasizing. But very importantly, they assist often in doing something and managing the complex system. Not merely understanding it, but managing it. Of course, using the understanding to help manage it more effectively. So they could serve as these what-if tools to identify desirable policies, where desirable can be defined for different contexts in different ways. It can mean robust under the uncertainties. It can mean high leverage in terms of bending those curves we care most about. It can be cost-effective in terms of getting the biggest bang for the buck. It helps us evaluate benefits of restructuring the system, understand trends, see to what degree this trend we saw might be explained by these factors. Does it jive with, if we assume this, is it consistent with it? Helps us prioritize research and data collection, spot uncertainties that are particularly influential in terms of what we're anticipating coming forward, or in terms of the trade-off between policies as we perceive them through the model. It can help us understand classes of contexts where certain strategies are best applied, and help us translate something that's learned in one context to another more effectively. Finally, they can serve as really powerful communicational tools. As you'll see, they're very visual constructs. Okay, so what are the characteristics of these sort of models? Well, they depict the behavior of a system over time. It consists of evolving state, the state of the system, the status, the situation of the system advances over time. So we saw it this morning, right? The status of that population was depicted in that visualization we saw. Who's infected, who's not, and so on. And that was advancing over time. We saw it go from just being a tiny red speck to spread out and proceed. These models, very importantly, they specify incremental change. They don't actually say, make the system have a disk that will expand at this rate. Not at all. What they say is, if you're in this susceptible state, you can get infected if you've been contacted by someone who's infected. If you're in an infective state, you recover with a certain rate. That's kind of an incremental change. To say, okay, contingent on this being the case, say for an individual, how does it change? Or for a system dynamics model, it might say, okay, if you have this many people with pre-diabetes, there's a certain rate in terms of people per unit time by which they will develop diabetes. Certain rate by which they'll die, and so we specify incremental change given the current state of the model. If you have this many people with pre-diabetes, this many will be developing diabetes over the coming, in the course of the year, at this rate per month, or rate per week, or rate per year. The system behavior here is emergent. We don't pre-program that expanding disk. We don't say it should be gray inside and yellow outside. We don't tell it that. It tells us that. It's emergent. It's emergent from the model. Why is it so important? Because the world exhibits lots of emergence. Traffic jams being a case in point. There's nothing that's forcing there to be a traffic jam. It's a confluence of a bunch of factors, and that results from it. The model behavior typically over time cannot be pre-specified in closed form with a formula. And this is in contrast to a Markov model, actually, where we can sort of pre-calculate with traditional Markov models. Because the underlying systems exhibit non-linear characteristics, models generally do as well. And this is, again, a difference from a Markov model. Here, the whole is greater than the sum of the parts. They lack closed form specification behavior over time. We can't write down what it's going to do. We have to simulate it. They often exhibit counterintuitive behavior. The response to multiple interventions is very different from the sum of responses to each intervention isolation. And so it is with the world, ladies and gentlemen. Sometimes interventions that we undertake work across purposes. Sometimes there's synergies between them. Sometimes we get a major gain by combining them, much more than if we had either one in isolation. And we can capture that with models. They exhibit this sort of history dependence. We might make a change early, and it'll make a big difference. If that infection dies out early on, if it's blown out just after it lands, it'll make a big, big difference what you see 100 time units hence, 100 days hence, compared to if it had taken. So it's kind of a classic example of path dependence. There's lock-in effects. You can get effects where the situation is totally different depending which way it goes. I talked earlier about the dementia ward or vicious cycles in relationships. Similar types of things that we'll sometimes see in interactions between individuals. We can get these lock-in effects where it's harder to undo later. It's much easier to avoid it than it is to deal with it once it's in place. And sometimes the tail wags the dog. There are certain groups where all the action's at, and the others it's more minor, and so we can target our interventions. So, ladies and gentlemen, I'd like to get close to closing this lecture with just a reflection on models, analogizing to something that we all have worked with, and that's maps. Ladies and gentlemen, maps are extremely useful constructs we depend on, whether they're electronic or whether they're paper. We depend on them so heavily for many aspects of our daily toing and froing. Maps are very different depending on their purpose. They abstract away from a lot of details, but what's captured in a given map will differ a lot of what you're trying to get out of it. If you're trying to drive across Saskatoon, you'll use one sort of map. If you're trying to figure out how to bike across Saskatoon, you'll use a somewhat different map. If you're trying to understand why flooding occurs in certain areas, you use yet a different map. And if why brownouts occur, yet a different type of map, an electrical connectivity map. Some of those maps will incorporate topographic features. Some will abstract away from that. They all abstract away from a lot of detail. You're not going to find maps that have every blade of grass, every crack in the sidewalk. But they're still really useful. What details they omit depend on their purpose. So it is with models. We are not trying here. You're not in this boot camp trying to create a perfect representation of the world. You will never do that, any more so that you'll have a perfect map of the world. The only perfect map of the world is the world itself. The only perfect model of the world is the world itself. What you will be doing is creating a simplified representation. In maps, it is useful that they are simplified. They let you cut to the chase and understand how your needs will best be met in terms of the abstractions that's shown, how you'll get from A to B or why flooding's occurring. And so it is with models. We abstract away from a lot of details that seem extraneous, certainly people's hair color, aspects of the vagaries of certain components of their behavior or their clothing or what have you. But we capture details that seem important for our research questions. So what we omit depends on how we're going to use it. All models that sometimes said are wrong, but some can be useful. So it is with maps. They're wrong in the same sense a map is wrong. It's wrong because it hides a lot of detail. But the very incompleteness of what allows us to confer value. Often the fact that it depicts just a subset of information allows it to be simulated in a reasonable time, but it also lets us more clearly understand its behavior when we see it, than if it was just as tangled as everything in the world. So models are like maps. They're specific to purpose. They inevitably involve simplifications, but they can be useful despite being simplified. One proviso with models, as it turns out, it's harder to know what should go in and what should be left out than with a map. We have to do a lot more experimentation. And this comes to this sort of observation that Jeff is fond of quoting, of Francis Bacon, one of the fathers of modern philosophy of science, of philosophy of science. I don't know what modern. And he said, in Latin phrases that I won't try to copy, he said, it is better to evolve truth, it's easier to evolve truth from error than from confusion. And the way I like to put it is, it's better to be transiently wrong than be perpetually confused. Fail early, fail often, is maybe how it would be put today. Try something, observe the consistency with what you're trying to get, and correct. And that's going to be a lot better than sitting back and saying, well, we don't know what to do. Yeah, but
Question, you said wrong a couple of times. I'm curious,
Yeah.
with this modeling, is there a quantitative metric of when it's wrong, or is it intuitive as to how you determine if it's wrong or right?
Well, the issue is not whether there is one. The issue is what you're going to choose for different purposes. And I will see if we can talk some about this issue of confidence building in models and falsification of models. It's an issue in statistics. It's an issue here. The actual quote on all models are wrong, some are useful is actually quoted by George Box, the famous statistician. And he had in mind statistical models at the time. But the same thing is true with dynamic models. In both cases, they're abstractions, right? They simplify certain details. There are certain processes that we undertake that will help to ensure that a model is going to be appropriate for its use, and that will help cross-check and make sure that it's not really out of whack with what we know. And there are quantitative measures for doing that, techniques for doing that, and there are also process investments which we can make that will make it far more likely the model will be responsive to our real needs, to the needs of stakeholders, and responsive to how we're going to use it. And I'll see if I could talk some about that. It gets related to some of the issues with calibration, okay, later within this boot camp. So the idea here is that it's better be transiently wrong than perpetually confused. Try something, observe the consequences, and learn from it. And you're absolutely right that there are ways that we can spot inconsistency that are very, very cut and dry. Inconsistency with empirical data, because we are comparing, just as in a statistical model, against the actual quantitative data using a quantitative metric, and there's a large numbers of them that are sometimes used. And there's also non-parametric statistical tests like the Kolmogorov-Smirnov test or the Mann-Whitney one-way U test or what have you that you will sometimes use. But the point here is that with a model we have some systematic way of replacing confusion by learning. In other words, we have some way of taking some ideas about the way things might be, adding up, having the computer add up the consequences of, and comparing it with empirical data and seeing the degree to which it jives, or comparing it with our observations at a more gestalt level for being in the system. Is this similar to what we see? Sometimes it's really hard and fast data. Sometimes it's observations at a qualitative level about the patterns that we see. And both of those are useful for helping to cross-check the model, helping to question it, helping to advance it if it doesn't jive with it. So, these sort of models support theorizing concerning what's going on out there, and they aid in theory building, testing, and refinement. So, models at different stages of the process can aid in theory building, aid in testing theories, aid in understanding the consequences of theories in terms of their collective outcomes on distal factors or in terms of trade-offs between interventions. So even putting forward a poor model often advances knowledge by helping us spot these inconsistencies between our assumptions and the evidence. A common concern in this area is model scope. What quantities are generated by the model itself? We call these endogenous quantities. We saw that this morning. The number of people infected over time was endogenous. It was generated by the model. We did not tell it what to put in. There are some quantities we put in. The assumption for contact rate, the assumption for recovery time. We told it, represent this, use it, but use it in a pre-specified way. And then what quantities are ignored within the model? They're just left out of the model. So we didn't put certain things in this morning, for example, about strength of immune response. We could have. There are models we have that have dynamics of immune responses, but that was left out of that model consciously. It was ignored from that model. And it's a very fruitful thing to be able to distinguish these, and over time a given modeling project will often evolve between them. Okay? And capturing additional factors endogenously adds complexity, but also adds flexibility and investigative power and sometimes accuracy. But there's a real trade-off because often we want to think more clearly about the issues with a simpler model without presupposing that it's a full representation of the world by any means. But then we use bigger models to capture textured context in ways that might be more responsive to, say, planning intervention trade-offs. So a couple of take-home messages. Addressing larger health challenges in health and healthcare is especially hard because they exhibit features of complex systems. The whole is greater than the sum of the parts. Just as Don Berwick said, we can have micro-optimization within pieces of the healthcare system and, very adverse consequences for the system as a whole. System sciences provide us with tools to represent reason about behavior of complex systems. They help us reason through sort of the consequences of our assumptions. And they express dynamic hypotheses. That little unassuming thing we saw this morning was susceptible, infected, recover. That was capturing and collectively with who was a neighboring person and the contacts between them, etc. That was a dynamic hypothesis. It reflected, if we assume this, okay, what's the consequence? And these models help us understand how diverse factors related to health and health disparities combine to yield observed patterns. How all these factors from different things, contact networks and people's natural issue of infection and the demographics and aspects associated with changing behavioral norms, how do those ripple through to at the level of the entire system? And it helps us understand how intervention might affect health disparities. These models are specific to purpose. We do not build a model of Saskatoon. We do not build a model of TB, in the United States. The model will be different for different needs. And multiple and hybrid modeling types, it turns out, are going to be complementary for describing complex health challenges. So I'm going to stop this particular lecture here, but I'm going to